about whatever we are sharing today. So we are going now to share the pre-record I did with Professor Anderson, and I will see all of you later on. Thank you very much.
Well, good afternoon to you, ladies and gentlemen.
We are sharing today.
Those of you who were watching 2 weeks ago will remember that in our opening session, I had introduced you to the basics of what we now know about cardiac development. So today, we're going to extend that initial information, and we're going to look at the development of the atrial chambers. But let me remind you what we discussed in our introductory session. Today, we're going to need to know the building blocks of the atrial chambers. Where do they come from? I'm going to concentrate on the part that is most important in determining atrial identity. But in our previous session, I pointed out to you that in the past, we depended very much on speculative interpretations to understand normal development. But now, as I showed, we can really look at the evidence. We can appreciate properly what's going on during cardiac development. And that's what I'm going to do today, because when we think about atrial development, those speculations led to very many myths. And today, I'm going to try to turn those myths into realities. So let me remind you again that the evidence that I'm going to present before you comes from a series of embryos prepared using the technique known as episcopic microscopy. That was prepared by my good friend Tim Mohan. I'm also going to be sharing with you the images that come from the interactive PD files that have been prepared by my colleagues, the University of Maastricht, Professor Wout Lammers, Dr. Joel Hicks-Bowes. But today I'm going to reinforce those with important information that came from an earlier series of embryos we looked at. In fact, that's whilst Professor Lammers was still working in Amsterdam, and it's work we did together with Alexander Cesarov. And then I'm going to supplement that with the information I've gained from the data sets available from the Human Developmental Biology Resource, which is now housed in Newcastle. I also reminded you last week that we're going to look at what happens in the mouse. We're going to compare that to what happens in man. And the key points in the mouse are graded according to embryonic days. And you'll see those on my slides. E standing for embryonic day, and they're through embryonic day 8.5 through embryonic day 14.5. The human material that we're going to compare with, we grade that using what are known as the Carnegie stages. And they stretch from about 4 weeks of development, which is Carnegie stage 9, to 7 or 8 weeks of development, Carnegie stage 23. And those are the stages we're going to be looking at during today's presentation. So let's get on with it, and let's look at atrial development. Now, if we want to know where the different parts of the atrial chambers come from, we first have to establish how many parts are there in the developing atrial chambers. And as you see, I've emphasized here 5. One of these may be new to you, but it's particularly important. It's the part I'm going to call the body. And in fact, as I will show you, that is the initial part of the developing atrial chambers. The appendages are particularly important because, as you know, it is the appendages that give the chambers their morphologic identity. Then we have the venous components, another part that might be new to you, the vestibule. I'm going to show you where that comes from, and of course, the septum. So we're going to finish off by considering how the atrial septum develops so as to divide the right from the left atrium. But let's look at the definitive part first, to understand where we find these different components. I hope you'll appreciate that here I've opened up the right atrium. It's one of the lovely photographs taken by Diane Spicer. And if we look into the right atrium in this particular heart, we can see both venous valves. I'm going to emphasize the venous valves because it is with the appearance of the venous valves during development that we can recognize the boundaries of the systemic venous sinus. So there, as we look at the posterior wall of the right atrium, we can see those venous valves showing us the boundaries in the definitive heart of the systemic venous sinus. There on the back wall of the atrium, we find the septum. But in this particular heart, we can see a small space between the left venous valve and the septum. And that is the part of the body that ends up in the right atrium. We then see the pectinate muscles, which mark the appendage. And as you all know, the feature of the morphologically right appendage is that the pectinate muscles extend all the way around the vestibule of the tricuspid valve. And the vestibule is important because, like the systemic venous sinus, the body, it is smooth walled. So we distinguish the pectinated appendage from the smooth walls of the remainder of the atrial chamber. We can turn our attention now to the other side and we can look at the morphologically left atrium. And the larger part of what we're going to call the body, the part of the developing atrium that we see earliest in development, ends up in the morphologically left atrium, and it has smooth walls. There you see the pulmonary venous sinus, and it forms the roof of the left atrium. If you look through the body and see the horns of the atrial septum, and there we see smooth-walled vestibule, which is where the atrial myocardium inserts into the left atrioventricular junction. And then there you see the pectinated part of the left atrium, much smaller than the right atrium, because as you all know, I hope, the left atrial appendage is hooked. It has a very narrow junction with the body of the atrium. That is the appendage. So these are the parts we need to look for, and we need to determine from where they come. So I'm going to show you how they are formed and from where they are derived. And so we're going to go back to the starting point when we can first see a heart contained within its pericardial cavity. This is about the beginning of the 5th week of development. The head is beginning to fold. And there we see pericardial cavity, and the heart, or rather the heart tube, is within this pericardial cavity. There you see the yolk sac, which is the endodermal layer of what initially was the embryonic plate. And there is the neural tube, which is the back of the plate-like embryo at this stage. We can look inside and we can see that there is myocardium developing. There is the development, the left ventricle. We're beginning to get some myocardium around the right ventricle. But if we look inside, and this is the beauty of having these PD files, we can see what's happening in terms of the developing venous component of the embryo. Because there we see the veins are bringing the blood back from the placenta, umbilical veins. We can also see a plexus of veins that lies on that endodermal layer, the yolk sac. And they come together to form the venous tributaries. And at this stage, the venous tributaries lead directly into what eventually will become left ventricle, which gives rise to the outflow tract and supports the bilaterally symmetrical aortas. We can see the same thing in the developing mouse. We can see that reconstruction made by Jill and Wout, the human embryo, is more or less the same of what we see in the developing mouse. This is one of the scanning electron micrographs made by my very good friend and colleague, Nigel Brown. I worked with Nigel for quite some time whilst he was at St. George's Hospital. Like myself, Nigel is now retired. But he made this very nice dissection by picking away the pericardial cavity. And there you see the heart tube. And as I pointed out in our previous session, the majority of what we see at this early stage will become the left ventricle. But already at this stage, there is new growth from what we call the second heart field. There you see the growth of the venous pole, and there you see the growth of the arterial pole. And with this additional growth into the pericardial cavity, we get bending of the heart tube, and that gives us the ventricular loop. And it's now at this stage when we see the ventricular loop that we can also, for the first time, see what is going to become the atrial component of the heart tube. And this will end up as the body of the atrium. At this stage, we can also see its communication with the inlet of the ventricular loop. And we know the left ventricle derives from the inlet of the loop. The right ventricle develops from the outlet of the loop, giving rise to the outflow tract. So we can now replicate this in the developing human embryo. So here we are, Carnegie stage 11, the beginning of the 5th week development. And there now we see the venous tributaries coming together from the yolk sac, the umbilical veins, and they're entering through what we call the hepatocardiac channels. And they are forming bilaterally symmetrical venous tributaries. As in the mouse heart, we can see that they are coming together to form what will be the atrial component of the eventual heart tube, which, as you saw, gives rise to the atrioventricular canal to the ventricular loop. And there, the ventricular loop is supporting the outflow tract. So at this early stage, another important point is to emphasize the myocardium, which is surrounding the heart tube, is what we call primary myocardium. And as I've explained, with the atrial component, that will give rise to what we will call the body. The so-called chamber myocardium, and that's going to give rise to appendages, develops by the process of ballooning. And here you see the cartoon I also showed you in a previous presentation. This was prepared by my colleagues in Amsterdam, Moorman, and it shows you the essence of ballooning. What you see in gray is the primary heart tube. And what you see ballooning from the atrial component in parallel fashion in blue are the atrial appendages. In our next session, we're going to go on to consider development of the ventricles. And we'll emphasize how in the ventricles we have ballooning series, developing left ventricle, the apical part of the left ventricle ballooning from the inlet of the loop, the apical component of the right ventricle ballooning from the outlet of the loop. But today we are concerned with what is happening in the atrial component. So that primary myocardium will persist as the body of the atrial chambers. It is the appendages that will be produced by the process of ballooning. So let's see how that happens. So we're moving on here one stage. We're now into the 5th week of development, Carnegie stage 12. This is what the embryo looks like when we look at it from the front. And here you can also see the ventricular loop. But as I've emphasized, one of the beauties of having these interactive PD files is that we can take away the parts that we're not particularly interested in at this particular time. We'll come back to them when we look at the ventricles. But for the time being, let's concentrate on the atrial part of this developing heart. So here it is, same embryo. I've removed the ventricular loop so that you can see what is going on at atrial level. So there are our umbilical veins. They're still colored in purple. And there are the vitelline veins, colored in gray. And at this stage, they're bilaterally symmetrical. They are coming together, as we discussed, to form the hepatocardiac channels. But now they're also receiving the veins that are developing within the embryo itself, and those are what we call the cardinal veins. So these bilaterally symmetrical venous channels come together and they form what we call the horns of what will become the systemic venous sinus, the sinus venosus, if you will. And the horns of the sinus venosus on each side are committed to the developing atrial component, and that primary component of the heart tube that we call the atrial component will eventually become the atrial body. Already, however, you can see the beginning of the ballooning appendages, and they are ballooning ventrally. But there is the atrioventricular canal, and it is now taking its exit from the left side of what will become this primary atrial component of the developing heart. So, at this early stage, the systemic venous tributaries are symmetrical, and they're draining in symmetrical fashion to the body. If we are to achieve septation, and that will be the final stage of development we will consider, we have to remodel the systemic venous sinus so that it opens to the right side of that primary atrial chamber that will form the body. And this happens very rapidly. In fact, by the next stage of development, we're beginning to see that shift. In fact, here is the initial stage where we still have symmetry. We're looking at it now from the right and behind, so there is the body of the atrium. And another important consideration is that at this stage, the body of the atrium is still attached to the pharyngeal mesenchyme. That's going to become important when we consider development of the pulmonary vein. But let's look at these sinus horns, because there you see the left sinus horn, the right sinus horn, and on each side, sinus horns are receiving systemic venous tributaries in symmetrical fashion. Cardinal veins are draining the blood back from the embryo itself, the umbilical veins bringing the blood back from the placenta, the vitelline veins draining blood from the yolk sac. Stressing again, at this point, there is symmetry in the way these venous tributaries and sinus horns connect to the body of the atrium. But here we are at Carnegie stage 12. Let's just go one stage forward. Here we are, Carnegie stage 13, still in the 5th week of development, but now very rapidly there has been this major change in the orientation and drainage of the systemic venous sinus. Because there is the systemic venous sinus, which is shown in dark blue, and you will see now it is draining only to the right side of that primary atrial component. So left sinus horn has now lost its connection with the body of the atrium. There is the dorsal mesocardium, which shows us the midline, and there you see how now the left sinus horn has remodeled itself by shifting rightwards so as to bring all the systemic venous return into the right side of the body, the atrium. I can turn that around and I can show it to you from the front. And now we're looking from an episcopic data set, human heart, prepared by Dr. Mohan at this same stage of development. And I've sliced through the atrial chambers so that now you can see the boundary between the systemic venous sinus and the body of the atrium. And as I told you, it is the venous valves that mark the boundary between the systemic venous sinus and the body of the atrium. And there, as you look at the back wall of the atrium, you can see these venous valves. And you can also see opening into them the superior cable vein, the superior cardinal vein, the inferior cardinal vein, the inferior cable vein rather, which has developed through, which eventually will develop through a series of changes that we're not going to have time to look at today. But also entering into systemic sinus is the left sinus horn, because the left sinus horn has now remodeled so as to occupy the left atrioventricular groove. We're going to come back and we'll look at We're going to look at septation, but coming from the roof of the atrium, we can see the first sign of the primary septum, and that is separating the body into a part that will end up on the right side and a much larger part that will end up on the left side. What I want you to notice is that how, with the remodeling of the left sinus horn, it has achieved its own walls and it is separate. The body of the atrium, it exists as a separate venous channel within what will become the left atrioventricular groove. So this shift of the systemic venous sinus has been such that all of the blood coming back through the venous tributaries will now enter into the right side of what was initially the primary atrial component of the heart tube. And it is that rightward shift that sets the scene for subsequent septation. Now, there's another key stage that has to take place, because at this initial stage, the body of the atrium is connected by the atrioventricular canal only to the developing left ventricle. So let's look at that again. And we can see that by taking the cavities and looking at the entirety of the cavities at the same stage. You can see the ballooning of the right atrial appendage, the ballooning of the left atrial appendage. It's the formation of the appendages that eventually will permit us to distinguish what is morphologically right from what is morphologically left. But at this stage, the atrioventricular canal is connected only to the developing left ventricle. We can see that again in another of Dr. Mohan's episcopic data sets, again from a human embryo. There now you see the body of the atrium. The systemic venous sinus is now delimited by venous valves, but we can now very nicely see how the ballooning has given us a right atrial appendage, a left atrial appendage, but at this early stage, the atrioventricular canal is attached only to the developing left ventricle. So another key stage that has to take place is expansion of the atrioventricular canal, because it is expansion of the atrioventricular canal that brings the cavity of the right atrium into communication with the right ventricle, and it is that expansion that will form the inlet of the right ventricle. And we'll talk about that in much more detail in our next session when we talk about ventricular development. But what I have to stress at this stage is that that atrioventricular canal myocardium, which exists at this initial stage, becomes the atrial vestibules. So there is another of our atrial building blocks. The atrioventricular canal myocardium will become the vestibules. And we can see very nicely how that happens by looking at this next stage of development. Carnegie stage 14, we're now getting towards the middle and the end of the 5th week of development, and it's looking much more like the heart you recognize in your postnatal echocardiography. Look how nicely we can see the right appendage. We can even see its pectinate muscles. The left appendage is also ballooning out in finger-like fashion. And there, very nicely, you see that atrioventricular canal myocardium. But now the canal itself has expanded such that the right atrium is looking directly into the developing right ventricle. And we know that when the insulating plane develops so as to separate the atrial myocardium from the ventricular myocardium, it will form in such a way as to sequestrate that atrioventricular canal myocardium as the atrial vestibules. So the vestibules are the remnants of that atrioventricular canal myocardium. So now we've discussed the systemic venous sinus. We know the appendages balloon. We've seen that the atrioventricular canal myocardium becomes the vestibules. What about the pulmonary vein? Now that is another topic that in the past has been contentious, but we now have the evidence to hand that lets us show you precisely from where the pulmonary vein develops. So to show you this, I'm going to go back to the mouse again and take you to the dissection made by Professor Brown. You remember this is a scanning electron micrograph. It's a mouse embryo in embryonic day 8.5. And again, the primary atrium is the initial primary part of the heart tube. And what we can now do, or what rather Professor Brown has done, is cut away the developing left ventricle so we can look into that primary atrium from the top. And this is what it looks like after we've tilted the heart tube towards you. So there at the back now, you see the gut. And I mentioned previously the dorsal mesocardium. This scanning electron micrograph shows you very nicely how the dorsal mesocardium produces continuity between the walls of the developing primary atrial component and the pharyngeal mesenchyme. There at the bottom, or rather at the dorsal end of the primary atrium, you can see the opening of the systemic venous tributaries, that big hole. The right sinus horn. The left sinus horn is not quite as large because it is moving rightwards, as you see, so as to remodel itself into the left atrioventricular junction. That then permits the dorsal mesocardium to provide the entrance for the pulmonary vein because the lungs are developing behind the heart. And we can see how they can then gain their entrance to the left side of developing atrium in this other scanning electron micrograph, again prepared from a developing mouse. Because as you look now into the dorsal part of the heart, you see those, the venous valves, which are marking the boundary between the systemic venous sinus and the primary atrium. And you see, as I've already shown you, it's opening only to the right half of the primary atrial component. You see these two bulges, and they are marking the reflections of that dorsal mesocardium. And between them, that connection that existed to the pharyngeal mesenchyme is showing you where the pulmonary vein will open into the developing heart. And we know exactly how that happens by having access to these embryos that were serially sectioned by Alexander Caesaroff whilst he was still working at the University of Amsterdam. And he took serial sections from these human embryos and he marked them so as to show genes. So what you see here in purple, or pinky purple, is the marking of the NKX 2.5 gene. And as you see, that marks all the atrial myocardium. It's essentially a 4-chamber section. So that is the opening of the systemic venous sinus. And there is the left sinus horn, which is coming down behind the heart, remodeling itself into the left atrioventricular groove. And there is that space between those two bulges or ridges that mark the site of the dorsal mesocardium. And what you can see very nicely is that they are marked with purpley pink tissue exactly the same as the atrial walls. Now, one of the myths about development of the pulmonary veins is that it comes from the systemic venous sinus, the sinus venosus. Well, what Alexander did was he took the serial section next to the one I've just shown you, and he then marked this section with an antibody that showed you the gene TBX18, and we know that that marks the myocardium of the systemic venous tributaries. So there in green, you see the walls of the systemic venous sinus, and again in green, you see the walls of the left sinus horn. Now, if the pulmonary vein truly originated sinus venosus, it too would be stained in green. But there is the opening between the pulmonary ridges, the flexions of the dorsal mesocardium, and as you see, there is no green tissue. That is because the pulmonary vein has nothing to do with the systemic venous sinus. In fact, it canalizes as a midline strand within the pharyngeal mesenchyme. And when it canalizes, it opens through that gap between the pulmonary ridges, between the margins of what initially was the dorsal mesocardium. But significantly, it does so very close to the atrioventricular junction. And I can show you that in this image that replicates the parasternal long axis cut that you see as echocardiographers. So there you see the body of the left atrium. This is the developing left ventricle, and there is the atrioventricular canal. Note that the left sinus horn is now remodeled into left atrioventricular junction, and it has its own walls. And there now is the opening of the pulmonary vein, and it is directly adjacent to the atrioventricular junction, and it is a solitary venous opening. And we can see what happens when the model, the reconstruction, Jill and Wout have made of this stage. There you're looking at it from behind. Left sinus horn is incorporated into the left atrioventricular junction. And there is the opening of the pulmonary vein. And what you see in pinky purple here is the dorsal mesocardium marking the initial connection of the atrial chamber to the pharyngeal mesenchyme. And there's a particular part of that is important, right pulmonary ridge, and that grows into the heart as what we call the vestibular spine. And it is only very much later pulmonary veins enter by cannibalization and migrate up to the roof of the left atrium. There you see the left atrium, left sinus horn with its own walls, and it is only when the pulmonary veins reach the roof of the atrium that we see the superior interatrial groove. So now we know systemic venous sinus forms systemic venous tributaries. The pulmonary vein develops from a midline strand in the dorsal mesocardium, and then it cannibalizes the intraparenchymal pulmonary veins so as to form the pulmonary venous sinus. And it is only after that pulmonary venous sinus migrates to the roof of the developing left atrium that we can see the superior intraatrial fold. Many still call that septum secundum, but in fact it is not a septum at all. It is a fold between the pulmonary venous sinus and the wall of the developing what will become right atrium. And I'll show you that in just a few moments. So now that has set the scene for the understanding of atrial septation. We've shifted the systemic venous sinus to the right. We've seen the pulmonary veins canalizing in that strand and initially entering into the left atrium adjacent to the atrioventricular junction, but then migrating to reach the atrial roof. So what about atrial septation? Well, it is that rightward transfer that sets the scene. And again, we can see the importance of that by going back here to Carnegie stage 14. This is another histologic section to show you what's happening. There is the ballooning right atrial appendage, the ballooning left atrial appendage. And you've already seen that at this initial stage, the atrioventricular canal is connecting exclusively to the developing left ventricle. But there now in the roof of the developing primary atrium, we see the primary atrial septum. And the key point here, on the leading edge of the primary septum as it grows into the atrium, we have a mesenchymal gap. And as the primary atrial septum grows, it grows towards the atrioventricular canal. I can show you that much better in a section from an episcopic data set from a mouse heart. And here we are, it is a stage one further from what I showed you in human. As I've shown you with my white arrow, there has been expansion of the atrioventricular canal so that now the right atrium is looking directly into the right ventricle. And we can now see much better what is happening with atrial septation. Because there is the primary atrial septum and it is growing towards the atrioventricular canal. But note that it's broken down at its upper edge, where initially it originated from the atrial roof. And it is that breakdown that gives us the secondary atrial foramen. On its leading edge, we have a mesenchymal cap. And the mesenchymal cap is growing towards the inferior atrioventricular cushion. And it is the space between the mesenchymal cap, the inferior cushion, that is the primary interatrial foramen. But that primary interatrial foramen is going to close, and that is why the primary septum itself has to break away from the atrial roof so as to retain a passageway such as that the systemic venous return can reach the left side developing heart, and that passageway is the secondary foramen. But let's see what happens as the mesenchymal cap continues to grow towards the inferior atrioventricular cushion. And I'm showing you this again in the developing mouse heart. And I've closed up now on the area of the atrioventricular canal. Because there again is the primary septum with its mesenchymal cap, and now it's much closer to the inferior cushion. And the closer it gets, the smaller becomes the primary foramen. But now you see the significance of that other structure we've already discussed, and that is the vestibular spine. And this is tissue that has grown in from the pharyngeal mesenchyme and has produced enlargement of that right pulmonary ridge that flanked the initial opening within the dorsal mesocardium. And it is the vestibular spine that is going to reinforce the attachment of the mesenchymal cap to the inferior atrioventricular cushion. In fact, the vestibular spine has a very long history. And as you see in the image I'm showing you here, it was first illustrated in the latter part of the 19th century by Wilhelm His the Elder. He didn't call it the vestibular spine, he called it the spina vestibuli. There it is, in his picture shown as growing forward in spine-like fashion, and we've relabeled it the vestibular spine, because that is the key player in reinforcing the closure of the primary interatrial foramen. So there you see it, merging with the inferior cushion and blocking off the primary atrial foramen. And here we see it, human embryo, there is the vestibular spine. It has fused with the inferior atrioventricular cushion, closing the primary foramen and committing the pulmonary vein to the body of the left atrium. And we can see exactly the same thing in the developing mouse, but now we can see even better. The primary septum itself had on its leading edge the mesenchymal cap. The mesenchymal cap fused with the superior atrioventricular cushion, the superior cushion fused with the inferior atrioventricular cushion to separate the atrioventricular junctions. We're going to talk about that in much more detail next week, or rather 2 weeks' time, when we discuss ventricular development. But there is the vestibular spine that has reinforced the rightward side of the closure of the primary interatrial foramen. And it is these tissues, the mesenchymal cap, the vestibular spine, that together will muscularize and will form the true second atrial septum. And here we see it subsequent to the completion of septation in the mouse heart. There is the secondary septum, and it has been formed by muscularization of the vestibular spine along with the mesenchymal cap. That is leaving the primary septum as the floor of the oval foramen. There is the oval fossa, we see from the right side. And there at the roof, we now see the fold that many people call the septum secundum. It isn't a septum at all. It is no more than a fold, but permits the primary septum to abut against it so as to close eventually the oval foramen. So let me summarize for you what we have seen happening during atrial septation. Here we see that initial stage. There has been expansion of the atrioventricular junction such that the right atrium is looking directly into the right ventricle. I'm also showing you the systemic venous sinus, which is shifted to the right. There is the dorsal mesocardium. And as I've also shown you, the pulmonary vein will open into the atrium between the rims or the margins of the dorsal mesocardium. So the key stage in atrial septation is the formation of the primary septum, which grows from the roof, carrying on its leading edge a cap. And as that cap grows towards the cushions, so it will diminish the size of the primary interatrial foramen. So here we see the stage as the primary septum is growing towards the atrioventricular canal, carrying on its leading edge the mesenchymal cap, and the closer that gets to the cushions, so the smaller will become the primary interatrial foramen. But then the other key step that has to take place, upper part will break down so as to give us the secondary foramen that will permit the systemic venous return to pass into the left side of the developing heart. By now, the pulmonary vein has canalized as that midline strand and is opening between the margins of what was the dorsal mesocardium. So let's take it one stage forward. The mesenchymal cap has fused with the inferior cushion and has closed the primary foramen, and that has been reinforced on the right side by the growth of the vestibular spine. Now we have the secondary foramen between the broken down superior edge of the primary foramen and the atrial roof. And there the primary septum will form the floor of the oval fossa, and it will be infolding of the atrial roof that will produce the ridge against which the upper edge of the flap valve primary septum will eventually abut. So that then permits us to show you the completion of atrial septation with formation of the superior interatrial fold. That does not take place until the pulmonary veins have achieved their definitive position in the roof of the left atrium. And then it is the flap valve that will abut against the superior interatrial fold, eventually to close the secondary interatrial foramen. The mesenchymal cap and the vestibular spine will muscularize to form the anteroinferior buttress, the true second atrial septum, which binds the septal components against the insulating plane formed within the atrioventricular junctions, giving us the definitive oval fossa. And that is exactly what we see here in the formed heart. We see the right atrium, left atrium, the aortic root. There is the oval fossa, and the primary septum has now become the flap valve of the oval fossa. The mesenchymal cap, the vestibular spine have muscularized from the anteroinferior buttress. The so-called septum secundum is no more than the superior interatrial fold, separating the connections of the pulmonary veins to the left atrium, the superior table vein to the right atrium. So there we have it, atrial development. The atrial septum, the primary septum forms the floor of the fossa. The true second septum is that anteroinferior buttress formed by muscularization of the mesenchymal cap and the vestibular spine. So the big myth, the entity that many of you will still consider to be septum secundum, is in fact the superior interatrial fold. So let's put it all together. We started off by looking at the components of the atrial chambers, the body, the appendage, venous component, vestibule, septum. I can now show you from where they have all materialized. Because the initial atrial component, primary heart tube becomes the body. As you have seen, most of that ends up in the left atrium, a small part in right atrium. The appendage, they are the ballooning components. They are chamber myocardium, and that is why it is the pectinated components of that chamber myocardium in the postnatal heart, according to their extent, permit us to distinguish what is morphologically right as opposed to what is morphologically left. The venous components are incorporated into the atrium eventually, the systemic venous component from the systemic venous tributaries, the pulmonary vein by canalization of that midline pharyngeal strand. The vestibules are the atrioventricular canal myocardium, and the septum, we saw it growing. The primary septum forms the floor of the oval fossa. The true second septum is the muscularized vestibular spine and the mesenchymal gap. And there we have the origin of the atrial components, fitting perfectly to what we see in the postnatal situation.
So, thank you very much, Bob. Thank you. It's every time for me, it's a real pleasure to pre-record with you because we make a lot of comments about what you present and the way you present. So we welcome Adrian. I don't know, we see something, but now we see Adrian. There is probably some already some question we see in the chat.
I can't see any. They all seem very happy at the moment, but maybe Adrian and Diane have some questions.
No, there is a question about about PFO flap. Is possible to identify morphologically left atrium?
Don't understand the question.
He said that about the flap of the patent.
Yes, indeed. The flap indeed is always on the left atrial side. So when you see what we call the horns, that indeed is a good marker of what is the left atrium.
Yes.
So why don't Adrian?
Hello, can you hear me?
We can, yes.
Perfect. Good to see you again. I have many questions, but I probably reserve them for some of them when we'll discuss the conduction tissue, because we haven't touched on the conduction tissue on the atrial side. I think it's important, especially for us surgeons when we do the cuts onto the right atrium for different operations. I'll just touch on the embryology. First of all, I think any anatomy lesson on the heart should start with embryology. It is so useful today to have these embryological lessons before we understand the anatomy. They are very helpful. As Professor Anderson said, we have far less assumptions today and much more evidence. But what I would like to ask is about first the pulmonary vein, the initial pulmonary vein, because it introduces a bit of confusion. First of all, why do we call that structure pulmonary vein so early when the lung buds are not formed? More than that, the origin of the pulmonary vein, as Cesarov's sections showed, is not a venous tissue. It has nothing to do with systemic venous sinus. So it comes from the atrial chamber myocardium, or it comes from the pharyngeal mesenchyme. So why do we use that term, pulmonary vein?
It's a very good question. And the point you make is in fact an excellent one. And so probably at the initial stage, at Carnegie stage 13, you are correct. We can see that there is a depression. If we look into the heart, there is a depression between what we call the pulmonary ridges, which are the reflections of the dorsal mesocardium, and there is no communication between the atrial chamber at that stage and the vein, the lung buds, as you say. The lung buds are developing behind the heart. They're growing forward from the tracheobronchial groove. But in the pharyngeal mesenchyme, we see a midline strand. And you are correct. We should not call that the pulmonary vein. We should call it the pulmonary strand. But we know then that when we go to Carnegie stage 14, we can see that that strand has canalized. It's connected at the ventral end into the cavity of the left atrium. At the dorsal end, it's joined up with the plexuses that are developing within the lung buds. So at that stage, we should then describe it as the solitary pulmonary vein. So you are correct. We should start off with describing the pulmonary strand. We then have the solitary pulmonary vein that is connecting the pulmonary venous plexuses within the lung buds into the left atrium, and then it canalizes those plexuses, and as it canalizes the plexuses, it migrates up onto the atrial roof. So you are correct, that is a much better way of describing the evolution of the pulmonary vein. But the other point you made about the myocardium, I think it does canalize as an endothelial channel, and then it becomes surrounded by myocardium, and that is the myocardium. It's pulmonary myocardium, but then it becomes left atrial myocardium. And then when we eventually get the pulmonary veins incorporated to the left atrial roof, we cannot distinguish the one from the other. It's just myocardium.
Let's see. And should we still use the term anteroinferior buttress, or should we now move towards the secondary septum?
Now that's an excellent question. If I had my way, I would call it the secondary septum, but it is also the anteroinferior buttress. I think it's going to take a very long time before people stop calling the superior interatrial fold septum secundum. If it was possible to dictate what we were going to call things, we would say it is the anteroinferior buttress. The anteroinferior buttress is the second atrial septum. So that's another very good point you make.
And I'll touch on the last one. I think in the picture from Wilhelm His the Elder, people might see that the vestibular spine is linked to systemic venous sinus. And I just want to clarify this. It has nothing to do with the systemic venous sinus, because it seems that it comes from there. It is still coming from the pharyngeal mesenchyme and is linked with the right pulmonary ridge.
You are correct, but as it grows into the heart, it does take forward the inferior commissure of the venous valves. And indeed, that inferior commissure eventually ends up within that anteroinferior buttress as the tendon of Todaro. So it's the growth forward of the vestibular spine, I think, that brings the commissure of the venous valves and muscularizes around them. And that's very important. The other point you mentioned, the conduction system, because of course the atrioventricular node is distal to that within what eventually will become the triangle of Koch. So another very important point you raise, that it's the growth forward of the vestibular spine that brings that tendon of Todaro and attaches it to what eventually will be this, we call it the central fibrous body. We'll talk about that next week in the 2-week time. That is the area where all the tendon of Todaro joins in with the atrioventricular cushions to form that center point of what eventually will be the center point of the atrioventricular junctions.
And thank you very much. I apologize. Just another issue that came to mind when I saw the talk about systemic venous sinus. That's obviously a right-sided structure. And should we talk about that only after the left sinus horn shifts to the right? Because it's not, you know what I mean when you discuss it on the last slides, I think, with the sinus.
Correct. And another very good point you make, because as I showed at Carnegie stage 12, there's 2 sinus horns, each connect to the body of the atrium. And then there's this very sudden shift from Carnegie stage 12 to Carnegie stage 13. And that is as the left sinus horn becomes remodeled into the left atrioventricular groove. And it's only at that stage that we recognize the venous valves. And only when we recognize the venous valves can we then recognize the boundaries of what previously people have called the sinus venosus. We're now calling that the systemic venous sinus. And only at that stage do we recognize it as a separate entity. And as you say, at that stage, it is connected to the right side of the body of what was initially the primary atrium.
Thank you. And should we mention, because it has clinical application, what will be the postnatal venous valves, what they become?
Well, that's also a very interesting point. The right venous valve becomes the eustachian valve, the Thebesian valve. Part of it becomes incorporated into the terminal crest. Diane will be able to comment on this because Diane has looked at a lot of neonatal hearts and she has seen remnants of the left venous valve. They are not easy to see. Diane, maybe we could bring you in at this stage because you've looked at a lot of these neonatal hearts. Would you like to comment on how easy it is to see the remnants of the venous valves?
Actually, I've seen it in older patients too. I had a 74-year-old at autopsy who had virtually a double flap valve, if you will, but the anterior or right atrial component was actually the left venous valve that covered over the flap valve at the floor of the oval fossa. So essentially there was a double partition there. I do see small remnants that partially cover the inferior aspect of the oval fossa in a fair amount of hearts. If you know what you're looking for, you can see a little elliptical remnant of it associated with the inferior aspect of the oval fossa and joining the body of the right atrium.
And indeed, it's when you recognize the left venous valve that you can, as I emphasize, that you can then see the part of the primary atrium that ends up on the right side and which we can call the body. And previously, we've tended to ignore that on the right side, but it is there, as you say. And when you recognize the left venous valve, you can see how small it is compared to how much of the body ends up on the left side.
And thank you, Diane. Should we link this with a discussion around the Chiari network that we see, and also with some people would call core triatrium dexter or divided right atrium? Please, this is important, I think, for clinicians.
Indeed, that's a very good point you make there, because the Chiari network is persistence of much more of the venous valves, and as you say, that can be seen as a fenestrated network. On occasion, it becomes a windsock. And I don't know whether you've ever seen cases where the windsock can blow itself through the tricuspid valve. And they're very nice. I was involved with an adult cardiologist who showed these exquisite echocardiographic features. And you could see this windsock going backwards and forwards through the right atrium, and almost like it was blowing smoke. I don't know whether you've ever seen that. Have you ever seen that at surgery?
Yes, it happens. Yes, it happens. Mostly, of course, in neonates, we see this type of disease.
But have you seen it that this large enough that you have to resect it?
Yes.
As Adrian says,
Yes.
when it divides the right atrium?
I remember two cases. Was very arrhythmic. So the membrane was the Chiari network was able to make movements or some noise on the tricuspid valve, and the baby was very continuous on arrhythmia, and we decided after the removal was okay. And in another case was a real core triatrium dexter. It means the inferior vena cava was completely connected to the left atrium. Mm-hmm. Mm-hmm. This was the. There are two questions. One I think is very important from Susanna Unjanabi, and she asking if you can, make it again. You can. She doesn't understood about the role of dorsal mesodermal cap in the morphology of right and left atria.
The mesenchymal cap is the tissue that is on the leading edge of the primary septum. And this is something that has tended to be ignored in the past. So people have spoken of the primary septum growing towards the cushions and fusing with the cushions. In fact, it is the mesenchymal cap, which is part of the lining of the primary atrial chamber, that I showed in all the pictures. You could see it. We call it a cap. It is like something, if I put something on my head, that is the cap, and that is what you see during development. So when the primary septum closes, it is closed by mesenchymal tissue fusing with mesenchymal tissue, the mesenchymal cap with the inferior cushion, and then that is reinforced by the vestibular spine, which again is mesenchymal tissue. So all of this tissue is mesenchymal, and then the cap and the spine muscularize, and that is what Adrian says we should now call the secondary septum, which we also call the anteroinferior buttress.
Yes, I think Alejandro is asking a very good question, Alejandro Lozano. He asked about how does the pulmonary veins connect to the coronary sinus or the inferior vena cava in the anomalous pulmonary connection?
Well, that again is another very good question. We know that there are collateral channels throughout the pharyngeal mesenchyme. So as the pulmonary veins develop in the lung buds, they should gain their connection to what Adrian correctly suggested should start off as being called the pulmonary strand. If that strand canalizes and becomes a pulmonary vein, then the dominant connection will be between the pulmonary venous plexuses and the pulmonary vein. So we can presume that if the pulmonary strand does not canalize, then those pulmonary venous, intrapulmonary venous plexuses will retain those initial connections to one of the adjacent systemic veins. And so we may presume that it is failure of canalization of the strand that means that the pulmonary veins then take an alternate route to get back to the heart, and they do that through the systemic venous system.
You have some comments?
Yeah, I was just thinking in terms of, because there are several structures that will fuse to divide the atrium on the secondary septum now. Is there an order that we can say who fuses with whom, and where the superior atrioventricular cushion fuses with the rest of the structures?
Well, I showed that to an extent because I think the mesenchymal cap fuses with the superior cushion. I think the superior cushion then fuses with the inferior cushion. And then as the vestibular spine grows in, it grows in from behind the heart. So that is inferior. So it's the vestibular spine that then reinforces the inferior part. So I would say that the sequence is mesenchymal cap to superior cushion to inferior cushion, and then the ingrowth of the vestibular spine reinforces the whole thing.
Because it will be, thank you, that's important. It will be important when we discuss the embryological basis of atrioventricular septal defects.
Indeed it will, and also, as you know, I mean, recently, were you involved with the work we did with Rohit Lumba when we showed vestibular defects? Diane was, because Diane has also found, when she's been looking through the hearts in her own archive, in the Lurie archive, she's found a relatively large number of what we call vestibular defects. And they are holes within that anteroinferior buttress. They are true atrial septal defects. So Diane, what proportion did you find?
We looked in total of 2,100 hearts between 3 collections. 300 in one collection, 700 in another, and 1,100 in the other. And we found the same percentage in each collection, which I think was 3% of the hearts had a vestibular atrial septal defect. And they were associated with several other types of defects. I think the highest association was right heart defects like pulmonary atresia, intact septum. And I'm glad Adrian brought up that point, because I was going to make the point as well that it's very important to understand how those structures come together when you're describing ventricular septal defects, atrioventricular septal defects, and how the muscularization of the vestibular spine plays into those different defects. So that I know I asked you a short while ago about vestibular atrial septal defects, and your response was it was failure of the vestibular spine to join the mesenchymal cap, so that you end up with a defect in that secondary atrial septum. And for me, it's been very important to have all these concepts when I'm teaching, because I can go back and explain to people why these things are occurring. Just like the atrioventricular canal myocardium becomes the vestibules of the atriums. And without muscularization or formation of the vestibular spine, you end up with an atrioventricular septal defect.
Absolutely.
And so that's how you can explain there's no such thing as an atrioventricular canal type of ventricular septal defect.
Absolutely.
So this has all been very instrumental for me teaching.
Adrian, we should ask you also. I mean, you've looked through the Birmingham archive. You and I have looked through it together. And as I recall, we haven't seen any vestibular defects, have we? Maybe it's because we haven't looked hard enough.
I think you're right. In all honesty, we should go back, and actually I'll ask Diane afterwards if she could kindly send me a picture, if she has anything, or if it's published already, I can look there, of some images, because they may be tricky to detect them unless you see one.
Well,
what you're
as
looking
you know,
for.
when we looked through the archive, we looked through it relatively swiftly, and we were looking for the obvious defects. And I don't think we spent the time to explore the secondary septum on each occasion. But I mean, it might be well worth putting one of your BSc students to go back and to look at that.
Yes, and this is a call for everybody who's listening to, if they have access to such archives, to go back and look through their archives, because they might be surprised of what they see now. But if you don't know what you look for, you don't see it.
Exactly.
Many people think clinically that this defect is just a fenestration associated with oval fossa defects.
Yeah. And the thing, again, the reason we discuss who fuses is with what and when, it's when we discuss the atrioventricular septal defect, you know, we have a Rastelli classification still for what happens with the superior bridging leaflet, but we know that the inferior bridging leaflet many times is attached to the interventricular septal crest. So we have a good reason now to understand from embryology why that might happen and why it doesn't happen to the superior bridging leaflet. Maybe we'll discuss when we discuss the ventricular development.
Indeed, I will emphasize the importance of the vestibular spine to and indeed to ongoing expansion. I got some interesting things to show in 2 weeks' time when we talk about ventricular development. But Adrian, you were also commenting about the conduction system. Did you want to make a specific point about the conduction system in the atrium? Because the real key to me is the location of the sinus node, which is at the junction between the systemic venous sinus and the appendage, and is related to the terminal crest.
No, it was more to discuss both the location of both nodes. It will be important, and probably when we discuss the isomeric appendages and we discuss the mirror image arrangement of the appendage, probably it will be a separate session you think we should have for the conduction?
Oh, indeed. I think it is important, as you say, but I didn't, I mean, we already had 50 minutes today, so I've been told that the attention span of most people is 18 minutes. So I'm not sure how many were able to stay with us for the full 50 minutes. I know you did, and thank you for that. But it is a fact that it's hard going to keep all the way through the 50 minutes. At least it's available on YouTube so people can go back and revise it.
Yes. So Bob, thanks a lot, and thanks Diane and Adrian. You want to introduce the next On 8 October, we will discuss about development of the ventricular mass. So you want to say something about this?
Well, I will do the same thing for the ventricles as I did today for the atriums. I'll explain how the ventricles get their inlet, how they get their outlet, and the point that Adrian and Diane have both made. I will emphasize again the importance of vestibular spine in ensuring separation of the ventricular inlets. But what we'll also introduce next time is the importance of the outflow cushions. So the atrioventricular cushions separate the inlet. We're going to talk about the importance of the outflow cushions in building a shelf in the roof of the right ventricle to form the subpulmonary infundibulum. So all of that we're going to talk about next in 2 weeks' time.
I see a participant, Bettiger, is asking about septum spurium and how to differentiate the vestibular defect from the atrioventricular septal defect, ostium primum type.
It's a very good question about the septum spurium, because in fact the septum spurium is the superior commissure of those venous valves, and that is the superior margin of where the venous valves open into the right atrial appendage. And it's called the septum spurium, of course, because it's a false septum, and it isn't really a septum at all. And the vestibular spine is not an atrioventricular septal defect. It's a true interatrial defect. It's the only other true atrial septal defect other than the oval fossa defect, which of course is inappropriate formation of the primary septum, the flap valve. So it is not an atrioventricular, although, I mean, the point he's making, the vestibular spine is involved in an atrioventricular septal defect, but then it's absence of the vestibular spine that gives us the atrioventricular septal defect.
Thank you.
It might be important to note that when you have an atrioventricular septal defect and a well-formed upper portion of the atrial septum, that you can have a coexisting vestibular atrial septal defect as well.
Indeed, that's another very good good point you made.
Yes.
And Adrian, I'll send you that reference via email.
Thank you.
So thank you very much.
I'd just say thanks to Adrian and Diane for excellent comments and questions, and for fleshing out what we discussed. And we look forward to, we've had a good audience today, so hopefully we have as many tuning in for our next session. And thanks to you, Sasha, for your coordination. We'll see everybody in 2 weeks' time.
Okay, thank you very much.
Thank you.
Bye.
Bye.
Bye-bye. Bye-bye.